after the contraction is over. As long as the fetal presenting part is descending appropriately and it is the second stage of labor, this pattern is usually benign and requires no intervention. When you are monitoring a client who is in labor, you are responsible for identifying and interpreting changes in fetal heart rate patterns. When you see a non-reassuring fetal heart rate pattern, such as loss of variability or late or variable decelerations, you must intervene appropriately. To review, change the client's position. Slow or stop the oxytocin infusion. Provide oxygen by face mask at 8 to 10 liters per minute. And increase intravenous fluids to promote hydration. Here's a critical thinking exercise related to fetal monitoring. Your client, a gravida 1 para 0, is in active labor. LD cervix is dilated 4 centimeters, and her membranes are intact. The fetal heart rate and uterine contractions are being tracked by an external electronic fetal monitor. You note a baseline fetal heart rate of 110 to 120 beats per minute, and an adequate variability. There are no decelerations, but there is an occasional acceleration up to 135 beats per minute, lasting for 15 seconds. What would you consider reassuring or positive about this fetal heart rate monitoring pattern? The positive signs are adequate variability, no decelerations, and occasional accelerations. What do you think should be evaluated further? The baseline was 110 to 120 and is fine, but on the low end of normal. For now, you should just observe the fetal heart rate and its variability closely for any deterioration. Now consider this. 1 hour later, the only change in the monitor strip is that the fetal heart rate variability has decreased. Since variability is difficult to assess with an external monitor, you want to apply internal fetal scalp electrode. What must change for this to be an appropriate intervention? Your client's membrane must be ruptured, either artificially or spontaneously. Now the client says she needs to urinate. What should you consider and do? The client's membranes have not ruptured, so she can walk. You can disconnect the external monitor straps and assist her to the bathroom. If you feel the fetal status is uncertain enough that monitoring should not be interrupted, such as if the fetal heart rate pattern has late or variable decelerations, just bring her a bedpan. What is your role in the rupture of membranes? When the amniotic membranes tear or give way, anywhere from an uncontrollable gush to a trickle of amniotic fluid will follow. Be aware that membranes can rupture spontaneously before or at any time during labor. Or the physician or midwife might decide to rupture the membranes using a device called the AmniHook. The rationale for this amniotomy, or artificial rupture of membranes, called AROM, is to help shorten the length of labor, although the benefits of this procedure are debatable. Premature rupture of membranes, or PROM, before the onset of labor, and preterm premature prolonged rupture of membranes, called PPPROM, before 37 weeks gestation, are always a concern because of the risks to the client and the fetus, particularly infection and preterm birth, if delivery is not imminent. Amniotic fluid has a pale straw colored, is thin and watery, and lacks a strong odor. It can be difficult to distinguish it from vaginal secretions and urine without testing its pH with nitrazine paper. Amniotic fluid will turn the paper blue-green to dark blue, reflecting a pH of 6.5 to 7.5. Another test for identifying amniotic fluid is called ferning. When a small amount of the fluid is placed on a slide and viewed under a microscope, amniotic fluid will display a characteristic frond-like pattern. If the fluid is greenish in color, the fetus might have passed meconium in utero. Meconium-stained fluid is a common finding with post-maturity and breech presentation, but can also be a sign of fetal distress. Note the color and consistency and prepare for complications that might ensue. To assist with artificial rupture membranes, stay with the client. Once the amniotic sac is ruptured, note the time, appearance, odor, amount of fluid, and fetal heart rate and pattern. Document this information in the client's chart and on the fetal monitoring strip. Since the cord can prolapse with rupture of membranes, make sure you assess the fetal heart rate for several minutes after the procedure. If there are any abnormal findings, such as meconium-stained fluid, institute continuous fetal monitoring and notify the physician or midwife of any changes in rate and pattern. After the rupture of membranes, take your client's temperature every hour. Vaginal exams are limited to reduce the client's risk of infection. If the baby's head is engaged in the pelvis, the client may use the restroom with assistance. If the baby's head is not yet engaged, she must use a bedpan. In cases of preterm, premature, prolonged rupture of membranes, observe your client for labor. Take precautions to prevent infection, and administer antibiotics as prescribed. Remember that the complications of ruptured membranes are infection, fetal distress, and cord prolapse. If your client's membranes have been ruptured for more than 24 hours, she is much more susceptible to infection. Closely monitor fetal heart rate for any changes in pattern that might indicate prolapse in the cord. Remember that this is a true obstetrical emergency, and you must notify the healthcare team of any signs of maternal complications or fetal distress. How would you assess a client in preterm labor? According to the March of Dimes, 1 in every 8 babies in the United States is born prematurely, and among low socioeconomic populations, the incidence of preterm birth is even higher. So without question, you will care for a client in preterm labor if you choose to work in the area of maternal newborn nursing. Preterm labor is defined as the onset of regular contractions resulting in dilation and effacement of the cervix prior to 37 weeks of gestation. Be aware that preterm labor accounts for most of the perinatal deaths not attributed to congenital anomalies. In fact, compared with full-term infants, preterm infants have 120 times the risk of neonatal mortality. Women in preterm labor are advised to restrict their activities and avoid sexual intercourse, and might even be kept on bed rest with increased hydration. Tocolytic, or contraction-inhibiting therapy, might delay the birth long enough for antenatal corticosteroids, like betamethasone, to be given to accelerate fetal lung maturity. Factors that contribute to preterm labor are maternal age younger than 18 or older than 35, late or no prenatal care,